So our next speaker is Dr. James Haddock. He has, in the last couple of years, taken West Midlands BMA region by storm and is really, I think, reinvigorating that union, making that region a really effective region within the BMA. He's also an integral member of Team Hadissa, so he helped raise £366,000 for Hadissa Bawargaba's legal costs, which I think really changed the ballgame because that was when everyone started taking notice. And I think last thing just to mention is that he has recently been elected to BMA Council, so he exemplifies, he's very junior in his career, he exemplifies the kind of effectiveness that we're looking for in our profession. So thank you, James. Good talk.
Thank you, Musa, for that introduction, and thanks for organising this today. Thank you all for coming as well to hear what we have to say. There are some amazing speakers. I feel like a lump of coal amongst diamonds, really, but there we go. So I'm going to talk about the case of Hadissa Bawargaba today. That has been on the forefront of my mind for about the last 4 or 5 months. But before we start, I'd like this to be quite an interactive session. So could you pop your hands up if you're a non-doctor, just so I can gauge the audience? No, medical students, including doctors. So non-doctors, hands up. It just gives me a bit of an idea how to present the background. And if you're a trainee doctor or a medical student, pop your hand up for me. And if you're a doctor who supervises juniors or medical students, pop your hand up for me. Or if you have trainees, great. So we've got a lot of people who will probably have their own opinions on the Hadissa Bawargaba case in the audience. So what I'm going to do is I'm just going to quickly go through a brief background of the case, and I'd like you to bear in mind the words truly, exceptionally bad as I do this, okay? So, Hadissa Bawargaba in February 2011 returned after 13 months of maternity leave to her first acute shift as a paediatric registrar, with responsibility for clerking new patients, reviewing them, treating sick young kids. She returned on this first day. No induction, no handover. The registrar covering the child's assessment unit for new admissions was off. The consultant covering that unit was also not in the hospital because there'd been a mix-up with the rota and he'd gone to another hospital to go and give some teaching. The biochemistry or blood system was down, so bloods couldn't be checked with the computer system. We had to go through a laborious process where you telephone for results. The nursing team had gaps. On the paediatric side, they were covering those gaps with adult locum nurses who had no experience of paediatric nursing. She had one inexperienced SHO on her team in terms of inexperienced in paediatrics. And as anyone who knows anything about paediatrics, SHOs are very supernumerary because they're learning about a very complex, completely new system from an adult. And a first-year doctor with no clinical experience apart from the medical studies. She was covering 6 wards, 4 floors, and she was covering referrals, covering emergencies because she had the crash bleep. So, how's Hadissa's first day back at work on the on-call shift going so far? Do you think it's going well? Hands up if you think it's going well. Does it sound like her working environment is truly exceptionally bad? Would you like to pop your hands up? Do you think her working environment is truly exceptionally rare? Would you like to pop your hands up? That's also interesting, isn't it? So, unfortunately, on this fateful day, Jack Haddock came in. He'd been suffering from diarrhoea for about 3 days, diarrhoea and vomiting. He was sick. She recognised this. She saw that he looked dehydrated, he was lethargic, he had all the symptoms of someone who had severe dehydration. She took a blood gas, and it also showed that he was very sick. That's a kind of blood test for those of you who aren't doctors. She diagnosed gastroenteritis and severe dehydration, and she prescribed IV fluids to resuscitate him. She also recognised at that point that he was short of breath, so she ordered a chest x-ray. So, let's review how she's doing. Is that a competent assessment? Is it a competent differential diagnosis? Is it a competent first stride into management? Can you pop your hands up if you agree with that? Is that truly exceptionally bad care? Can you pop your hands up if you agree with that? No, I don't think anyone thinks that that's unreasonable. So she did that, she started treating him, and she went off back to work to see all the other dozens of kids she had to review and look after that day, including, at one point, she had to do a lumbar puncture on a small baby. Now, I'm an anaesthetic trainer, we have to do lumbar punctures. It's incredibly complex procedure, there's lots of different components, it takes a long time to get everything together for it. It can take up to about half an hour in anaesthetics, but when I have to do it on the ward, it can take about an hour and a half, because we don't have everything in one place and you have to find the equipment. I can't imagine how long it takes to do one on a baby. And she's got work piling up, and lots of things to do. So at this point, Jack goes for his x-ray, and Hadiza's busy. A little bit later, she reviews him. He's doing well, actually. He's responded a little bit, he's picked up, he's starting to play, and he's not lethargic anymore, he's wide awake. The blood test that she repeats shows that he's making some improvements. There was one thing that was missing on that blood test, but given that we're taught to treat the patient and not results, she assessed that he'd clinically improved. Most of the results confirm that, and she decided not to subject him to another painful, distressing blood test. I think that sounds reasonable. She reviews the chest x-ray. She sees a chest infection. She starts antibiotic therapy. It's given just within 1 hour, which is the limit for prescribing antibiotics in sepsis. And at this point, it's 3 hours after the event, because she's been really busy. Would you pop your hands up if you've ever took 3 hours to review an important investigation, or longer? And it's probably not because you're an incompetent doctor. It's probably not because you're truly exceptionally bad. It's probably because you're truly exceptionally stressed. You don't have time. You're not a time lord. You can't just hop through time and find these things in instantaneous time. And essentially, that meant that delay caused problems down the line, and I'll go on to explain it for those of you who haven't heard about that. So Jack stabilised, presumably, gets moved to the ward, and no one informs Hadiza. So normally, for those of you who aren't familiar, when a patient comes in and they're sick, they're stabilised in an acute assessment area, and then once they're stabilised, they get moved to a ward for care, but less intense periods of observation. No one's informed Hadiza about this. Then a little bit later, she meets with a consultant, she tells him about the case, she shows him the blood test results. He chooses, for whatever reason, we don't know why, not to review the patient. And then, about a little while after that, someone on the ward gives Jack a medication, because what I haven't told you about Jack is that he's got Down syndrome, he's got a very poorly heart, and because of his poorly heart, he's on a medication which lowers his blood pressure to reduce the strain on his heart, and which is very dangerous to give to a child when they have diarrhea and vomiting. Hadiza very correctly didn't prescribe him this regular medication. Unfortunately, an hour later, at the peak effect of this medication when it's given orally, Jack Haddock, his heart stopped, he arrested. Hadiza was called by the crash bleep. She went to the ward, she didn't know Jack was there. She did make a mistake at that point. She asked the team to stop CPR. An experienced team of an ICU consultant, an experienced nurse, stopped CPR at that point. About a minute later, people realised that she was talking about the wrong patient, another patient who did have a do not resuscitate order. Resuscitation was restarted. And that's where that story ends. And then I'll just take you through very briefly what happened then. So 3 years later, out of the blue from her point of view, she got a knock on the door from the police. They came and charged her with gross negligence manslaughter. About a year later, she was found guilty of gross negligence manslaughter and was given a 2-year suspended sentence. The jury found that her care that day was truly exceptionally bad. And then in June, after her suspension her period of suspended sentence had run its course, the GMC investigation came to a head, and they referred her to the MPTS for erasure. But the MPTS didn't agree with the GMC. They said she was an excellent doctor, she'd had an excellent, unblemished career. She'd worked after the event without incident, and that she'd done everything she could to remediate her training. And they said that erasure would be disproportionate. But the GMC wasn't happy with that. They wanted her, well, I mean, they say they took legal advice that said that the MPTS went beyond a jury and a criminal conviction that said she was truly exceptionally bad, and this wasn't appropriate, and took it to the High Court. And unfortunately, in January, her appeal won. And Justice Owsley, one of the two presiding judges, said, "The tribunal's decision to suspend rather than erase her contradicted jury who had concluded that she had given truly exceptionally bad care, and also said that there was no suggestion, unwelcome and stressful though the families around her were and the issues around her were, and with the workload she had, that this was not something she had not been trained to cope with." And I'd ask all of you, who can be trained to cope with those systemic failings that Hadiza found this day? It took me a long time to get a hold of this case. It was January this year. I mean, this happened way back in 2011. She was convicted in 2014, and I didn't hear about it. Maybe that's my failing, maybe that's my prejudice. I set it aside and I wasn't interested. But when I heard these facts, I felt a reflection of myself in her case, and I thought, I could be Hadiza. And I think most junior doctors feel that they could be Hadiza. And I would just ask the consultants and staff grades in the room, do you feel that your trainees could be Hadiza? Do you feel that you could be Hadiza? And that was the genesis of Team Hadiza. A couple of days later, I spoke to Chris, who had experience with crowd justice, and we decided that it was important that we could raise £10,000 because the profession needed an independent review. Is this right? What has gone on? So £10,000 was our target. Within about 24 hours, we'd raised about 200k, and in about 48 hours, we'd breached 300k, and then we finally settled on 360k and thought that's probably enough. At some point, Hadiza got in touch, and we got in touch, and we said, this is far more money than we need for a review. We'd like to offer it to you to take on your own independent legal team, and so she could have more control over her appeal. And it's proved extremely successful. So it's a glum case, but I'd just like to talk about what we've achieved. And I don't mean me, I don't mean Chris, I don't mean Musa, I mean we as a profession, because we came together that month in a fabulous way that we hadn't seen since the junior doctors' strikes, and it reinvigorated us. We've achieved a successful application for appeal, and Hadiza's appeal will be heard at the end of July. In addition to that, the BMA have asked to intervene in the case. I believe also the PSA, the GMC's overarching regulator, has also asked to intervene in the case, so that will be interesting to hear. We've had the Sir Nor Williams review commissioned by government, which has stripped the GMC of its right of appeal, which I think we could all applaud because it's used it quite vindictively. And we've also got a consultation on the definition of what we define as truly exceptionally bad. And the GMC has launched its own Dame Claire Marks review. This has all been done on the back of activists, grassroots activists, and the pressure that that's put on. We've also had an amazing BAPIO conference, which has allowed us all to reflect on the dimension of discrimination against black and minority ethnic people. But you might be wondering, what have we achieved? We've achieved a lot. Are we going to achieve more? What does the future hold? Well, I think our next target should be legislative change. Gross negligence manslaughter shouldn't be possible for a simple, honest mistake. There needs to be willful intent. And when we'd like English law to reflect what happens in Scotland, where there is an element of mens rea, there has to be some intent, has to be willful. I think also the future holds probably better black minority and ethnic representation. I went to this BAPIO conference and it struck me that very few white medical leaders were there. And I thought that was bad. I think white medical leaders, because medical leadership at the moment is predominantly white, need to go to these conferences, and they need to hear the concerns of black, minority and ethnic people, because there's probably a latent prejudice inside people who are privileged to disregard and not hear the voice, not be interested in, and we have to make an active effort to hear the concerns of black, minority and ethnic doctors and also women. So what else? I guess that brings us on to the last thing, which we hope that Hadiza will be able to appeal her criminal conviction. It's not clear yet whether that will be possible, but there is one route in which she could, and I don't think any of us will rest until we've cleared her name completely and overturned that criminal conviction. I'm sorry, I'm a bit sweaty. Thank you very much for listening to me ramble on.